So when you prepare and study the axial skeleton, I would start with the skull, and I would start with some of the primary bones, right? Get your basics down. Can you identify frontal bone and temporal bone, occipital bone, the paired parietal bones? Are you familiar with the sutures? Then go write down the sutures. Do I know the sagittal suture? Do I know where the coronal suture is? Do I know where the squamous suture is? Do I know where the lambdoidal suture is? Then start looking at the mandible. Do I know where the mandibular process is? Do I know where the coronoid process is? Do I know where the ramus is? Do I know where the angle of the mandible is? Do I know where the mental foramen is? Do I know where the mental process or mental protuberance is? Do I know where the maxilla is? Do I know the zygomatic arch or zygomatic bone? Do I know mastoid process, styloid process? Do I know external auditory meatus, internal auditory meatus? Then start looking at the foramen. Do I know the foramen ovale, foramen rotundum, foramen spinosum, the lacerum, foramen lacerum? Flip it over. Can I find the hypoglossal foramen? Looking at the skull from underneath, do I know where the jugular foramen is? Right, so just what I'm saying is, rather than just going around randomly, focus on, let me do all the holes, let me do all the processes, let me do all the major bones. Right, that's how you should, that would be my approach. And then when you look at the vertebrae, make sure you're familiar, and you could say to yourself, okay, I know there are 7 cervical vertebrae. I know there's 12 thoracic vertebrae. I know there's 5 lumbar. Do I know the main processes, the main parts of each vertebra? Do I know the vertebral body? Do I know the spinous process? Do I know the transverse process? Do I know the lamina, the pedicles? Do I know the difference between the superior articulating facet and superior articulating process? Do I know the inferior articulating facet, inferior articulating process? Do I know the difference, and can I identify the difference between C1 vertebrae and C2? Can I identify the difference and differentiate between the atlas and axis? Atlas is C1, axis is C2. Do I know that C1 does not have a vertebral body, right? C1 has the arches. It has an anterior arch and a posterior arch. C1 doesn't even have a spinous process. It has like a posterior tubercle, right? It doesn't really form a spinous process like C2, C3, C4. That's why C1 and C2 are referred to as atypical vertebrae, because they don't look like C3 down to L5. They're very, very different. Can I differentiate quickly, this is an atlas or this is an axis? Well, what do you look for on the axis? Look for that little stem sticking up, the dens or the odontoid process. Can I differentiate between a cervical vertebrae and a thoracic vertebrae and a lumbar vertebrae? Not just by level, because you will see a question like that on the test where I'll have an entire spine and I'll have an arrow pointing to one, and you'll have to know whether it's thoracic vertebrae 6, lumbar 3, 6th cervical, and that's just pure counting. It's not rocket science, but you'll have to know that, okay, the cervical vertebrae are smaller, lumbars are much larger. You can know that the cervical vertebrae all have bifid spinous processes. When you look at the spinous process, it's not one, but it kind of splits a little bit and becomes bifid. When you look at thoracic vertebrae, what's unique about the spinous processes is the direction in which they move. So if you look at a nose that typically is angled downward, and you look at a thoracic vertebrae and you rotate it laterally, the direction of the nose is the same direction as the spinous processes. That's with a thoracic vertebrae. When you look at a thoracic vertebrae from posterior, the transverse processes angle upward, like the wings of an airplane. They kind of go up just a little bit. So the spinous goes down and the TPs, or transverse process, goes up. Again, remember, for second exam for bones, you can't abbreviate. So you can't go TP, you'd have to write transverse process. You can't write L3, you would have to write lumbar 3. You have to know that L is for lumbar, T is for thoracic, C is for cervical. 7 cervicals, 12 thoracic, 5 lumbar. You know, you have 12 pairs of ribs, and each rib articulates with its corresponding thoracic vertebrae. So the first rib attaches to T1 vertebrae. The 12th rib attaches to T12 vertebrae. You should know the difference between the true ribs, the false ribs, and the floating ribs. Floating, the last two, ribs 11 and 12, because you'll notice when you look at them, there's no cartilage that attaches that to the sternum. True ribs have their own separate cartilage. False ribs have shared cartilage. Floating ribs have no cartilage. Also know the main parts of the rib. Where is the head? Where is the neck? Where is the body of the rib? You should also be familiar when we talk about the skull. I'm going to show you I just kind of Googled it because I wasn't sure if I covered it in one of my lectures. There are the sinuses. You know, everyone talks about, oh, I have sinus congestion. Oh, I have a sinus headache. Oh, my sinuses are infected. I think it's important to know where the sinuses are. So I would make sure that you can identify the frontal sinus, the sphenoid sinus, and the maxillary sinus, and the ethmoid sinus. Those are the 4 sinuses, and I will show you where you can locate them. What else and how else should you study? So that's pretty much the approach of how you should address the axial skeleton. Let's look at the appendicular, and I know I've done my recording, but let's show you. Let me see if I could bring that up. Give me a moment. Now, I like this PDF that I was able to locate. The PDF you can find, I'll show you where you can locate it, because I saw it this morning and I liked it, but it's in the common course. So let me show you where you can find that. Let's open up my screen share. Okay, so when you go to your courses, let me get back here. You should see something that looks like common AHS 131, companion material for AHS 131. Sorry, here it is. AHS 131 fall. If you click on that, and then we click on lab exam 1 on the left, I'm sorry, lab exam 2 on the left. Let's look at arm and hand model images. Let's see if this is it. Looks like they changed it around a tad bit, but let's take a look. Okay, this is pretty good. Not the one that I'm looking for. I will share it with you. Let me see if I can, if I pop this here in the, let me copy the link. Maybe this will get you there. Hopefully it does. Let's see what you can find. If not, Let me unshare my screen for a moment. Let's see if I share this link, if you will have access to it. I'm not sure, but it's worth a try. I'm going to put it in the chat. If not, then I will just see if you can, if it takes you anywhere. If not, I will post that link in our course and see if we can have, if we have better luck that way.
It worked for me.
Okay, thank you. Anyone else? It works. Perfect.
Yeah, for me too.
Awesome. So let's take.
I'm still trying to get it.
Okay. I will put the link also in our course to make sure you have access to it. So let me go back to the screen share and let's open that back up. So you should see this, right, as the first. And what this is showing is that everything here in the center is the axial skeleton, right? We did the head, we did the neck, the trunk, the spine, the sacrum, the ribs, that's all axial. And everything in the gray is going to be the appendicular system. And then it just tells you how many, 2 clavicles, 2 scapula, 2 humerus. So we know that there's 206 bones in the body, and they all formulate joints, with the exception of the hyoid bone, which is in the throat. It really doesn't form any type of official joint. So let's take a look here at the upper portion. And what we're seeing here is a little bit of the sternum, a little bit of the clavicle. You see the scapulae and you see the humerus. Yes, you do see the ribs with the blue individual cartilage there. So these would be true ribs up on top. Now, in terms of the sternum, you remember from last week, this upper portion here is called the manubrium. This is the body of the sternum, sometimes called the gladiolus. And then at the very tip, which we don't see, is the xiphoid process. Who remembers what this is called? This line right here going horizontally? Who remembers from last week what this horizontal line is? It's very important. Anyone? Okay, that's called the sternal angle, or the angle of Louis. The reason why it's important, because you're getting into healthcare, it's very important to know that when you palpate up here where the jugular notch is, that depression, if you go down about 3 finger breaths, this is 1, 2, 3 finger breaths below that. For some people, it may be 4. You get to this horizontal ridge, this line that you can palpate up and down. And when you palpate it, palpate means to feel. When you palpate it and strum up and down like you're strumming a guitar, you'll feel that horizontal line. It's very, very important because it will always take you to the second rib. Whether you go to the left of that or to the right of that, that landmark is always at the second rib. Well, why is that important landmark to know? It's very important to know because as you advance in your education and you become nurses or healthcare providers, and you put on the stethoscope, you put the bell or the diaphragm on different parts of the chest, not on a rib, but here on the intercostal spaces. The intercostal spaces are hollow. You can hear echoes of sound there much better than placing a bell of the or diaphragm of a stethoscope on bone. So once you feel the sternal angle or the angle of Louis and you palpate to the left or to the right of that, you feel a rib. If you drop down 1 finger breath, you get to the second intercostal space. If you go down another finger breath, third rib. Another finger breath, third intercostal space. And there's a very famous textbook out there by Bates, famous nurse Bates, and it's called Bates' Book of the Physical Examination. And whether you're examining the head, neck, trunk, ribs, liver, stomach, lungs, heart, they go over specific landmarks and where to place that stethoscope to hear sound. So that's why the angle of Louis, sternal angle, is of significance. Okay, here's the clavicle. When you look at the junction between the clavicle and the sternum, there's a joint. So we call that the sternoclavicular joint. As we move laterally, we get to the end of the clavicle where it articulates with the highest point of the scapula. That highest point of the scapula, this process right here, is called the coracoid process here and acromion process here. So we call this the acromioclavicular joint or AC joint, acromioclavicular joint or AC joint, sternoclavicular or SC joint. At the midpoint, when you palpate your clavicle, the medial portion is convex, right? It bows outward. And then the lateral portion, as you move laterally, it goes concave. The clavicle dips in right here. And it's at that concavity where most fractures take place. So if someone slips and falls and they fall with an outstretched hand, all of that force moves up through the hand. You'll probably break a carpal bone, most commonly the scaphoid, which is where the anatomical snuff box is, right here. If you lift up your thumb, there's always a little bit of a depression right there that's called the snuff box, anatomical snuff box. Right in there is the scaphoid. So that will usually break. When your hand stretches out, you'll typically break either the radius or the ulna, or where they create a fulcrum, you can fracture them both. Then the impulse moves up through the humerus, where you will typically fracture the clavicle right at the concavity. Okay, so you should be familiar with both the acromial end of the clavicle, acromial end, and the sternal end of the clavicle. Okay. This is because this is the end that articulates with the sternum, and this is the end that articulates with the clavicle. You can see that this one's a little bit broader. The acromial end is broader and a little bit flatter to meet the acromion process. So the shoulder joint and shoulder girdle, you'll hear me talk about that. The shoulder girdle is made up of the sternum, the clavicle, and the scapula. But when you hear the shoulder joint, we're specifically talking about the junction between the head of the humerus and the glenoid cavity or glenoid fossa of the scapula. All right. So let's move down a little bit. So again, you got the sternal end and the acromial end. And there's always a facet at that end that will articulate with the acromion. It just means flat surface, like the facets of a diamond, the chiseled flat surfaces of the diamond. There is a conoid tubercle on the top here, closer to the acromial end. And there is a costal tuberosity up here. The conoid tubercle is an attachment site for some ligaments to attach there. Let's look at the scapula. Now, when we address the scapula, it's a very irregularly shaped bone, and you need to be able to identify whether you're looking at a left scapula or a right scapula. In order to do that, you have to look at it from front and back and go, is there a landmark here that I can see quickly and identify that would let me know I'm looking at it from the posterior or looking at it from the anterior? There is that structure. When you look at the one on the right, you'll see that you have this spine of the scapula. If we point to this, it's not a spine, right? It says spine here, but this is the spine of the scapula because you have a spine centrally located, the vertebrae. So this is the spine of the scapula. If you look at it, it starts from the medial aspect. This is the medial border of the scapula, also known as the vertebral border. So on an exam, they're both acceptable answers, vertebral border or medial border. This medial border, right around here, you'll see that the spine of the scapula starts from there. It goes laterally and it moves superiorly and lateral, right? It doesn't go horizontal. It runs lateral and superior until it gets to the highest point of the shoulder, called the acromion or the acromion process. The scapula really only has two main processes. One is the acromion process. The other is the coracoid process, which you can see on the left-hand side. Acromion process is the highest point, and anterior to that, on the anterior view, is the coracoid process. Not to be confused with the coronoid process of the mandible, and not to be confused with the coronoid process that we'll get to on the ulna. So there's two coronoid processes and one coracoid process. The coracoid is on the scapula, okay? On the ventral side or the anterior side, it's just one large flat surface. So that's how you know whether you're looking at it from anterior or posterior. Anteriorly, it's just perfectly flat. There's this nice large fossa. On the posterior side, you have the spine of the scapula that differentiates and separates two fossas from one another. On the posterior side, there's a supraspinous fossa and an infraspinous fossa. Supraspinous fossa, infraspinous fossa. On the anterior side, it's the subscapular fossa. Now there's only one fossa left because the scapula has four fossas. We've already done three. Supraspinous fossa, infraspinous fossa, and the subscapular fossa. The last fossa is seen on the lateral aspect, which is here. It's here, but if we turn it this way, we're looking at it from the side view, it's either called the glenoid fossa or the glenoid cavity, interchangeable, glenoid fossa or cavity. This glenoid cavity or fossa is pretty shallow. It's not very deep. It's not like the hip joint where you have this ball and socket that's very, very deep. Instead of the depth of it, it's quite shallow. And because it's shallow, the head of the humerus can move around and dislocate pretty easily. It's why the shoulder joint is the most commonly injured joint in the body. So you have the head of the humerus that's sitting in the glenoid cavity, and the way I describe it is that the cavity is like a golf tee. You know, when people play golf, they put the tee in the ground and they put the golf ball on top of the tee. The golf ball is large. The golf tee is very small. So the golf ball can easily fall off the tee if the wind blows too hard. All right, so think of that relationship between the golf ball and the golf tee to the head of the humerus and the glenoid cavity or glenoid fossa. Okay, so we have four fossas. Now we have three angles: superior angle, inferior angle, and a lateral angle on where the glenoid cavity is, that lateral angle. We have three borders. We have a medial border, lateral border, and a superior border. The medial border and lateral border have two interchangeable names. The medial border is also known as the vertebral border, and the lateral border is also known as the axillary border. So the reason why it's axillary border, right? We learned from anatomical position and all the reference terminology that the armpit is the axilla. So this is the armpit here, so it's the axillary border. Again, superior angle, inferior angle, lateral angle, medial border, lateral border, superior border. Coracoid process, acromion process. Subscapular fossa, supraspinous fossa, infraspinous fossa, glenoid fossa. That's the flow of the scapula. These fossas are kind of important because when we do muscles, we will learn rotator cuff muscles. And there are four rotator cuff muscles: supraspinatus, infraspinatus, teres minor, and subscapularis. Three of the four that I just mentioned are going to originate on these fossas. So the supraspinous fossa is where the supraspinatus muscle originates. The infraspinatus fossa is where the infraspinatus muscle originates. The subscapular fossa is where the subscapularis muscle originates. Okay. Teres minor is going to originate somewhere off here, off the lateral or axillary border. Okay, moving right along. Again, just another view isolating the anterior view. Subscapular fossa, superior border, superior angle, inferior angle, medial border, lateral border, superior border, coracoid process, acromion process, lateral angle, and subscapular fossa. From the side view, we get to the highest point. That's the acromion process, and which means that this is the posterior side, and where the coracoid process is, this is the anterior side. So where the coracoid process projects anteriorly, that means this fossa here would be the subscapular fossa. The fossa up here, supraspinous fossa, because it's above the spine of the scapula. And then down here, infraspinous fossa, because it's below the spine of the scapula. So the spine of the scapula is a key landmark for posterior and differentiating the supraspinous from infraspinous fossas. So there's the spine of the scapula. Again, follow it up superior and lateral. There's the acromion process. Superior border, medial border, lateral border. Supraspinous fossa, infraspinous fossa. Vertebral border, axillary border. Lateral angle, superior angle, inferior angle. Now, I want to go back here for a second. There's two tubercles that I want to point out. When you find the glenoid cavity, on the top, right here, there's a little bump, and right on the bottom, there's a small little bump. Supraglenoid, like glenoid fossa, supraglenoid tubercle, infraglenoid tubercle. Why are these tubercles important? Because again, when we do muscles, we will learn triceps and biceps. The long head of the biceps originates here, and the long head of the triceps originates here. It's really important to understand these bony landmarks because it will carry over to when we do muscles. We're not just learning these bony landmarks for no reason, there's significance to them. Okay, moving right along, let's look down at the humerus. Now, when we look at the humerus, you have to be able to tell, hey, am I looking at this from anterior and posterior? These are always the questions you have to ask. When you're looking at it from the anterior and you look at the top, you're going to be able to see the greater tubercle and lesser tubercle, and right between the both, there's this groove or this sulcus. This groove that separates these two bony landmarks, greater tubercle and lesser tubercle, is called the intertubercular groove, aka bicipital groove. They're interchangeable. I personally like bicipital groove because from a functional standpoint, it tells us that the biceps tendon is going to travel through there. You can call it intertubercular groove just as well from a structural perspective because inter means between, intertubercular is between the two tubercles. So I'm okay with either. Greater tubercle, lesser tubercle. Planting a seed, not to confuse those with what you will learn next week. When we do the femur, there's a greater trochanter and a lesser trochanter. I don't want you confusing the two. Trochanter is in the lower extremity with the femur, tubercles, greater and lesser, with the humerus of the upper extremity. The head of the humerus is here. But the other thing to differentiate from the anterior side, besides that bicipital groove in the front, when you go and you move distally on that bone, there are two fossas at the end of the distal end anteriorly on the humerus. There's two fossas, whereas on the posterior side, there's only one fossa distally. Okay. So we're moving distally now from the anterior side. Here's the shaft of the humerus. And remember, the head of the humerus is going to project medially to the body. And the greater trochanter is lateral. So the head projects medially because it's going to articulate with the glenoid cavity. So if this is medial and this is lateral, as we move downward, this is the medial epicondyle. And out here on the lateral side would be the lateral epicondyle. The medial epicondyle, if you were to palpate an anatomical position and go to the medial part of your elbow, we can all feel that bump. That's the medial epicondyle when you're in anatomical position on the inside of the elbow. And if you move just a little bit posterior to that, here's the olecranon process, here's the medial epicondyle, and between the two, there's this groove. That groove is where the ulnar nerve is. That's your funny bone. So when you walk around and you accidentally bump that, you'll get a zing right down into your fingers, especially half of the ring and the pinky. That's the funny bone. Nothing funny about it. It is the ulnar nerve. Okay, so let's be able to identify the medial epicondyle versus the lateral epicondyle. What's the significance of that? The significance is if you were to put your left hand along the medial epicondyle of your right hand and place your fingers here, and then squeeze your fingers a few times and bend your wrist, you'll see that right here, you get the muscles right there, if you can see. These muscles contract along the medial epicondyle. If you put your hand on the lateral epicondyle and you extend your wrist up, you will feel movement along the lateral epicondyle. So the reason why medial epicondyle and lateral epicondyle are very important at the distal end of the humerus is the wrist flexors and wrist extensors are going to attach there or originate there. The wrist flexors originate on the medial epicondyle, the wrist extensors on the lateral epicondyle. Important. Okay, on my other video, you will see me demonstrate using the bony model, the significance of the radial fossa, the coronoid fossa, and the olecranon fossa on the posterior side. The radial fossa is this fossa on the distal end of the humerus where the head of the radius will articulate there. The coronoid fossa is where the coronoid process of the proximal part of the ulna will attach there. And then the olecranon fossa is for the olecranon process to articulate there. So when I look at these bones here, if I scroll up a little bit, here the radial fossa is for the head of the radius to articulate with. Here, the coronoid fossa is for the coronoid process right here to articulate with. And that's only in extreme flexion. In extreme flexion, the olecranon fossa is exposed, it's opened. But when you extend the elbow, it becomes closed and the olecranon process of the proximal ulna will fit in perfectly into the olecranon fossa of the distal end of the humerus. Okay, so you may have to like pause that when you rewatch that and listen to that portion all over again, okay? But that's important from a functional perspective. All right, let's look here at the forearm. Again, posterior and anterior. When we look at it from the anterior, you can see this nice depression called the trochlear notch. Now, this trochlear notch is going to fit perfectly into this area called the trochlea. The head of the radius is going to fit perfectly with the capitulum. This capitulum is convex, it's round, and it's going to articulate perfectly with the radial head. That's going to allow for your forearm to supinate and pronate, supinate and pronate. If it wasn't for the junction between the proximal radius and the capitulum, you wouldn't be able to supinate and pronate. It is that articulation The junction between the trochlear notch and the trochlear, there's no supination and pronation that happens between the ulna and the humerus. It's a lock joint. But this beautiful articulation here, if you look at the proximal radius and the proximal ulna, right in here, there's a radial notch. This radial notch is on the proximal ulna. It's this concave indentation that allows the head of the radius to perfectly rotate in that concavity. It's perfectly articulated to allow for rotation or supination and pronation. So the radial notch is on the ulna. Now there will be an ulnar notch, which is on the radius, but they're at opposite ends of the bone. Okay, so head of the radius articulates with the capitulum. Trochlear notch articulates with the trochlea. Trochlea means spool. If your mother, if you have a parent that sews or a grandparent that sews, if you look at the sewing kit, you'll see that the thread is on a spool. That's what a trochlea actually interprets in terminology, spool, like spool of thread. All right, distal to the head of the radius, there's a radial tuberosity or radial tubercle. Very important landmark. Why? Because that's where the biceps tendon inserts to, right? When muscles contract, the biceps starts up here, it goes down the arm, it attaches to the radius, and when this muscle contracts, it pulls on the radius and flexes the elbow. So the radial tuberosity is important. As we move down the shaft of the radius, we get to the very, very end of the radius called the styloid process or radial styloid. On an exam, if it's asked, both are acceptable. Radial styloid is shorter. If you want to put styloid process of the radius, you can. There is a radial styloid, and then there is an ulnar styloid. What's interesting in terminology is if you look at the head of the radius, it's proximal. But where's the head of the ulna? All the way at the distal end. So it's kind of flip-flop. Head of the radius is proximal, head of the ulna is distal. But both styloid processes are distal. The radial styloid is a very important structure. It's where a muscle called the brachioradialis inserts. And we will learn that when we do muscles again. What's unique about the brachioradialis muscle, we call it the politician muscle because it's the handshaking muscle. It flexes your elbow in the neutral position, right? This is supinated, this is pronated, this is neutral. There is a muscle of the lateral forearm called the brachioradialis. It is the only muscle in the body that originates at the distal end of one bone, which is the distal end of the humerus, at the lateral epicondyle, and inserts at the distal end of another bone, the end of the radius, or radial styloid. There's no other muscle in the body that originates at the distal end of one bone and goes to the distal end of another, just a unique characteristic. Okay, remember up here, I pointed out the radial notch that's on the proximal ulna. Well, there is an ulnar notch that is on the distal end of the radius. It just allows the radius and ulnar to articulate and form a joint with one another. Okay. Okay, we're getting close to the end here. And at the very end, we are looking at the anterior and posterior hand. Now, again, you have to be able to look at the hand and say, am I looking at this from front or back? Because everything changes. When you look at the hand from the front and we look at the carpal bones and we zoom in here, there is a bone called the pisiform. It is anterior. It sits on the triquetrum. To give you an idea as to where that bone is, just imagine that you're using a mouse pad. You're using a mouse to move your cursor on the screen. Your pisiform is along the pinky side and would sit and rest on your desk as you're moving the mouse. That bone that you can all feel, it's pretty prominent, that's the pisiform. It's anterior. You can't see the pisiform from the posterior side, which is what you're looking at on the right side of the screen. Left side is pisiform. The carpal bones are divided into two rows, a proximal row and a distal row. Proximal and distal. There are 4 bones in each row, and you need to know what the 4 bones are in each row, so you should learn them from lateral to medial. You would start from the thumb side. And from the thumb side, if we look at the 4 bones, it's scaphoid, lunate, triquetrum, and pisiform. Now, there are some silly mnemonics out there that you could use to remember. There are some clean ones out there. There are some dirty ones out there. So if you explore some anatomical mnemonics, you'll be able to find them to help you remember them, okay? I learned some when I was in chiropractic college that helped me learn these. You can uncover some of them. Some of them are silly. There's many out there, even in the textbook, to help you with it. So scaphoid, lunate, triquetrum, and the pisiform. The next row, starting from lateral to medial, here's 1, 2, 3, 4. It's trapezium, trapezoid, capitate, and hamate. The hamate has a little hook off of it. This right here is actually the hook of the hamate. The carpal bone that's fractured most commonly, the carpal bone that breaks most easily, is the scaphoid. And again, if you look at your thumb and you go thumbs up and you look, there's going to be a little depression right here. And if you put your finger in this depression and then take your hand and you ulnar deviate, you feel a bone that pushes up right against your finger. The bone that's pushing up right here, that's the scaphoid. So when you do a clinical history, if someone slips and falls and they go, oh, I landed on my hand and I have such pain, and they go, where is it? And they go, it's right here, it's deep. And they x-ray it, most likely it will be a scaphoid fracture. The carpal bone that subluxates most commonly, means that it can shift and move very easily, is the one that's right in that center, right here, pretty close, and that's called the lunate. The lunate can actually subluxate and put pressure on the median nerve, causing carpal tunnel syndrome. And when someone has carpal tunnel syndrome, they have neurological radiating pain to 1, 2, 3, and half of the ring finger. Okay? And typically the pain is exacerbated if they take both their hands and they flex them like this. If they flex them and you get shooting pain to 3.5 fingers, 1, 2, 3, and half of the ring, that's indicative of carpal tunnel. Okay? All right, so what else do we have? So make sure you know the carpal bones, know that there's 8 of them, know that there's 2 rows, a proximal row and a distal row, know that the proximal row from lateral to medial, scaphoid, lunate, triquetrum, pisiform. The pisiform sits anteriorly on the triquetrum. Then at the thumb, trapezium, trapezoid, capitate, hamate. The capitate perfectly articulates with that third metacarpal. Carpals, metacarpals. Meta means after. So after the carpals are metacarpals. These carpals start at the thumb. So the thumb is digit 1. The pointer finger is metacarpal 2. The birdie is metacarpal 3. The ring finger is metacarpal 4. The pinky is metacarpal 5. So if we point to this on an exam and we go name this, you have to say metacarpal 2 or second metacarpal. Now we move down to the phalanges. The phalanges are 14 of them. 14. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 3 times 4 is 12. The thumb only has 2. It has this section and this, whereas all the other fingers had 1, 2, 3 sections. So if we look at digits 2, 3, 4, and 5, there's a proximal, a middle, and a distal phalange. A proximal, a middle, and a distal phalange. If we look here on the right side, they label them proximal, middle, distal. Proximal, middle, distal. So if we pointed to this on an exam, you would say this is the fourth middle phalange, fifth distal phalange, second proximal phalange. Well, what is this? If I pointed here, what is this? First proximal phalange. A lot of students make a mistake and they call this a middle phalange. It's not the case. This is not proximal, middle, distal. This is the first metacarpal. The thumb does not have a middle phalange or phalanx. It only has a proximal and a distal. Okay, let's just make sure I didn't miss anything, any of these landmarks for you. Okay.